Welcome, everyone. Thank you all for joining us for this virtual event on understanding attitudes towards the COVID-19 vaccine. I'm Diane Weber, Executive Director of SHSMD at the American Hospital Association, and I will be your moderator for today's conversation. This webinar is part of AHA's Joining Hands for Greater Impact series. Over the past year, hospitals and health systems have taken on unprecedented challenges in the face of the COVID-19 pandemic. This included not only treating COVID patients, but also accessing PPE, ramping up testing, responding to their community social needs, and now efforts to educate and vaccinate individuals across the country. In many cases, hospitals and health systems did not do this alone. They have forged new and sometimes non-traditional partnerships to meet the needs of their patients and communities. At the AHA, we have had a front row seat to see how these relationships have formed and evolved over time. The Joining Hands for Greater Impact series highlights how these partnerships have enabled the hospitals and health systems to respond to the pandemic. We would also like to note that this event was funded in part by a cooperative agreement with the Center for Disease Control and Prevention. The contents of this event do not necessarily represent the policy of CDC or HHS and should not be considered an endorsement by the federal government. At AHA, we also have a professional membership group for healthcare strategists and marketers known as SHSMD, the Society for Healthcare Strategy and Market Development. If you're involved in strategic planning, marketing, business development, or communications, we hope you're already a member of SHSMD, joining thousands across the country who share ideas such as the ones you'll be learning about today. Please join or learn more at shsmd.org. As of today, 67.8% of the adult population in the United States has received at least one COVID-19 vaccine dose. While that is excellent progress, we know that many people are still reluctant to get the vaccine. And we know that you've been trying a variety of different approaches to encourage vaccination. Vaccine hesitancy can be related to a combination of factors. According to the Kaiser Family Foundation Vaccine Monitor, unvaccinated adults recently reported that the main reason they have not yet gotten the vaccine is primarily the newness of the vaccine, followed by being worried about side effects, the fact that they don't trust the government, that they don't think they need the vaccine, and they just don't want to get it. Vaccine strategies at this point require more insight into attitudes, perceptions, and values that might influence hesitant behaviors. In June, the California Coronavirus Testing Task Force developed a report that by now you've all seen called Human-Centered Recommendations for Increasing Vaccine Uptake. Today, we are going to learn about various behavioral archetypes for individuals so that we can better understand how to address vaccine hesitancy. We'll kick things off with a presentation from David Grandy, Vice President, and Caroline Franz, System Designer, both on the Delivery System Strategy and Innovation team at Kaiser Permanente. They will be sharing a brief overview of what they learned from their research. Then after their presentation, we will be joined by three panelists from hospitals and health systems representing different roles to have a conversation about how to apply the learnings from the report to support vaccine efforts. Throughout the presentation, feel free to add your questions or ideas or experiences in the chat, and our presenters will do their best to respond back. David and Caroline, I now turn it over to you.
Thank you, Diane. Thanks for the great introduction. It's great to be with everybody this morning. Thanks for joining as part of this conversation. So I want to spend a few minutes just giving folks a sense of where it is that this work has come from. As Diane mentioned in her opening remarks, the work was commissioned by the California Testing Task Force. And initially our charge in working with that organization was to help the state of California's Department of Public Health understand the relationship between human behavior and public health guidance. And we spent the better part of 6 or 7 months working very closely with the statewide testing task force, CDPH, and a number of different county health organizations. Of course, as vaccines came to market and emergency use authorization was granted, we began to shift our focus away from the human factors of testing to understand the human factors with vaccine uptake. And those included a myriad of issues, including access, equity, trust, behavior change, and even the service experience when people went on site to get vaccinated. So the research work took a number of different forms. First, we completed a nationwide ethnographic study to understand people's COVID-19 vaccine beliefs and values, their attitudes, their worldview, their culture logic, and how all of those things affected choice. We set up a website to understand online behavior, to see how people behaved, what messages resonated and didn't with folks, particularly among the Black and African American community. That website and that study generated millions of data points that we then combed for insight. We also brought together some of the leading thinkers nationwide from design and innovation organizations, different nonprofit and philanthropic organizations, to really understand how work that they had done, either in the vaccine uptake space or in other adjacent areas, could potentially inform our work. And it's really through that combination of inputs that we developed the report that you have all seen. That report and the learnings we'll share today have been distributed extensively, not only within Kaiser Permanente and the state of California, but also with vaccine manufacturers and even the White House vaccine task force. So if we go to the next slides, I want to talk a little bit about archetypes, because you'll see as the basis of the work 7 specific archetypes, and it's important to clarify what it is that we mean when we say archetype. So know that the intention and purpose of an archetype is fundamentally to understand human behavior and to make sense of that behavior at scale. It's important to know that these behaviors that we identify really aren't meant at all to suggest that any one person universally subscribes to those behaviors or acts in accordance with them. And this fundamentally is how archetypes differ from stereotypes. And I want to make that point really clearly. Stereotypes, I think as we all know, tend to be these kind of monolithic descriptions, if you will, that are projected onto individuals in a population. And in many cases, they are completely unsupported by data, very different than the archetypes that we're presenting. Also important to know that these archetypes cut across every demographic factor that you could imagine: age, gender, race. Fundamentally, at the end of the day, they are informed by the attitudes, beliefs, and behaviors of real people who have participated in these studies with us and that we believe are representative of the population at large. And they're helpful for precisely that reason. They give us some insight into how similar people at any given point in time may express similar attitudes, even for very different reasons. So the archetypes really give us good insight into those reasons, the why, if you will, so that we can leverage solutions to solve for the why. As mentioned, the archetypes come from extensive research that was conducted by our team. They have also been validated with quantitative data from the Kaiser Family Foundation, as well as academic journals, including the New England Journal of Medicine and the National Academy of Sciences. And certainly as new information, new research is introduced nationwide, including the CDC's most recent vaccination attitudinal study, we have continued to validate and update this thinking. So I want to talk very quickly about a couple of frameworks that will help us sort of put in context each of the 7 archetypes. And I think these frameworks are fairly valuable in any of our work as we think about solutions. As we look across the sort of spectrum of archetypes, we can begin to map these different groups to different types of engagement strategies that are focused on increasing vaccine confidence and uptake. So on the left side of this slide, we have the folks who are maybe the least motivated to get vaccinated. For this group of folks, larger cultural shifts may be required, and we're going to have to invest a tremendous amount of time, really starting yesterday, investing in the emotional and belief and intellectual driven spaces that these folks live and work and play in every day. And at the same time, ensuring that when somebody makes that decision when they overcome whatever that sort of mental barrier was to getting vaccinated, that we make sure it is exquisitely easy for them to get vaccinated, and that the experience that they have on site is great. For those in the middle who are, say, closer to a yes, our approaches, we believe, should emphasize motivating these individuals positively, of course, providing needed information clearly, succinctly, and plainly, introducing behavioral nudges of all kinds, and again, making sure that the service experience of vaccination is simple, smooth, and accessible, largely meeting people where they are in non-traditional venues from time to time. And lastly, of course, we have those who are very ready and willing, or who have already been vaccinated, frankly. For this particular group, the strategy is to inspire them, to share their belief, their motivation, the why it is that they were vaccinated, and to have conversations mobilized around inspiration with those who are still on the fence. So this framework of archetypes is really sort of a 10,000-foot view of vaccine beliefs and behaviors. Helps us orient ourselves to the types of strategies that we can use to move that needle to get more folks vaccinated. But we know that in practice, there are always going to be folks who refuse to get vaccinated. And so on the next slide, our thinking here has been really about how it is that we reach what we have called the movable middle, that group of 4 or 5 archetypes sort of in the center of the previous frame that we think with investment, we can certainly get to be vaccinated. So to further understand what it is that it might take to motivate those individuals in the movable middle, we can apply the approach that you see on your screen right now, which is all about informing, equipping, and empowering individuals and communities. And in the simplest terms, we might say, we first need to listen to these individuals, not show up from a place of trying to convince them, but first to understand what those concerns are, and then to meet with information that is accurate, that is plain, and that is understandable. Second, we need to leverage trusted messengers to have conversations, deep conversations, long-term conversations with these individuals where they are. We want to make this as personalized as possible, so those trusted messengers, in many instances, need to come from the community or the culture or the world or belief system that individuals operate from. And it's really then and only then that we can move to this third phase, which is asking people to join us and to get vaccinated. That requires a tremendous amount of trust and credibility to be established before we even make that initial ask. So with those frameworks in mind, Caroline are going to take you through, at a high level, the archetypes and a couple of recommendations for each. So Caroline, why don't you take us through the first?
Excellent. Thanks, David. So everyone, we're going to start on that left side of those that are most hesitant to vaccinate. And our first archetype is the Steadfast Opponent. And this group is really against getting the vaccine and do not see themselves getting the vaccine in the near future or far future either. Often this is because it deeply opposes their beliefs, their systems around, politics, religion, their ingrained values, and they do not trust the vaccine or the efforts behind it. And they're just very steadfast in staying their ground in that mindset. But we think that we can increase confidence with this group, and they will require more than just facts. They want to be heard, and they want to have a place to speak and feel like they're being listened to and, validated is very critical. Their personal information or personal communication systems and networks are key. Social media, grassroots campaigns, and in-person canvassing may be needed to reach them on what feels like a more intimate level, something that's in their day-to-day and in front of them always. And often this group has a religious or trusted family member or leader who they will listen to and look to for advice. And so finding and leveraging these leaders and relationships is also another tactic that might get us a little bit of headway.
So the second group is what we call healthy independents. And this is a group of folks who believe that the vaccine is just fine for everybody else, particularly those who are most vulnerable to SARS-CoV-2. But they trust that their own good health, their healthy behaviors, and their immune systems are going to protect them against severe cases of COVID-19. So in general, they're not particularly worried about contracting COVID. They have a mindset that perhaps all of this has really been overblown. So to increase vaccine confidence with this group, we might think about a couple of very specific strategies. The first is we don't want to emphasize this idea of herd immunity, which can be somewhat elusive, or this idea of we're all in this together and behave in ways that are for the community good. Instead, we want to really personalize both the messages and incentives to vaccinate. So talking about, for example, the need to get vaccinated to have easy entrance to events or to travel or to re-engage with members of the family who may be vulnerable. These are all good strategies. The second is that we want to be able to sort of convey and communicate the reality and degree of risk that comes along with contracting SARS-CoV-2 if you're not vaccinated, but to do that in ways that don't sound alarmist. As soon as there's this tone of almost extremism or that things may be worse than they really are, that we're over-exaggerating, this particular group will shut down and tune out. So we need to tailor these messages to folks in ways that are very factual and bringing unbiased science forward, and again, conveying that in ways that are just plain and simple and all about the facts. And finally, again, consistent with our initial framework, deep listening and starting with understanding to really tease out why it is that these folks feel like they are immune and so forth, without getting into debate or relying on directives is really important. Again, and this is true across the archetypes, validating concerns and acknowledging opinions that these individuals carry is also effective.
And our third archetype is the Concerned Skeptic. This group is fearful of side effects, and that could be long-term, short-term, middle term. They're just really worried about the health implications and what that specifically would mean for their unique health condition. They will likely not consider the vaccine for years to come, and they don't want to rock the boat with their current good health status that they've achieved through, being mindful of medication, doctor's visits, etc. So a few approaches that might work to move this group a little bit. First is to personalize communications through care teams and physicians. These experts are their most trusted sources and should communicate condition-specific information that this group has questions about. What does it look like for me specifically, someone my age with this condition and this, part of the, condition itself. Second is to highlight monitoring effects and new longer-term data that shows vaccine safety over time. This could include clinical trial successes with those who have similar conditions, just that they can see oh, someone like me has been vaccinated and is doing really well. The third is to provide geographically accessible and at-home vaccine solutions for those with chronic conditions or mobility limitations. Often this group has been very vigilant to masking and social distancing measures and has stayed home and doesn't want to have to go into public around other people to get a vaccine, which they see as a very vulnerable circumstance.
So our next archetype is what we call the indifferent individual. This is a group for whom getting vaccinated just isn't top of mind. They may not think that it's necessary. This is an archetype that tends to skew younger in terms of age demographic. They may just not prioritize taking the time in particular to schedule an appointment. Getting vaccinated for this particular archetype is viewed as an enormous inconvenience. They're busy. They have work, they have social groups, they have entertainment, and certainly as the world is, quote unquote, moving back to normal, this is a group that says, why bother? So emphasizing for our indifferent individuals convenience and looking at access in non-traditional venues that largely meet people where they go, that are adjacent or embedded into their daily routines. Certainly for many, while doctors' offices and clinics, places that are highly distributed like that are good for some, for this group, it would be more about having vaccines at a place of work or in a movie theater or a grocery store, as an example. Persistent and consistent communication for this group is also important. We need to overcome that barrier that getting vaccinated is not top of mind. Having longer hours at sites, walk-in availability, so no appointment scheduling is critical. We also want to make sure that we highlight the long-term risks of contracting SARS-CoV-2 for this particular group. They think about SARS as being more like a 14-day flu, as opposed to something that could have longer-term health consequences, particularly consequences that affect their social activities and lifestyle behaviors. Here again, as with many of the other archetypes, we want to leverage messengers who have shared values, who come from a similar age or demographic, who have maybe shared the opinions and views of this particular group. Also, interestingly for this archetype, we really want to de-emphasize government officials and what we may perceive as experts. These are messengers that for indifferent individuals tend not to resonate.
The next archetype is the cautious supporter. And this group believes that the vaccine is helpful, but they have a few reservations about the side effects, this kind of pending, maybe not need for the booster shot, or some other unknowns for themselves and their loved ones when getting the shot. And a few recommendations for this group. The first is to use risk-based messaging that highlights risk comparisons as well as vaccine development facts and evidence of the efficacy and safety. Those are their kind of major hotspots of concern. The next recommendation is to provide easy avenues to answer questions. If they can find a one-stop shop of frequently asked questions and easily find one that they have in mind and see some resolution there, that would be incredibly helpful. Right now, they're trying to assemble their knowledge base by doing multiple searches and going down wormholes, and that often is more frustrating and confusing than what they set out to achieve. The third recommendation is to conduct direct physician outreach to communicate that the risk of COVID is likely much higher than the risk of what might happen during or after vaccination. They do look to physicians and medical experts as trusted individuals. And so making sure that we equip them with the right talking points and answers is critical. And finally, to host accessible education sessions that parents or concerned individuals can join to ask questions and to learn more from pediatricians, specifically regarding their child safety, now that more of the teenage population and adolescents can begin vaccination. So just making sure there are multiple avenues to get some questions answered would be very critical for this particular group.
So the next archetype is what we call reluctant Vaxxers, and we'll address these folks fairly briefly because these are individuals who are more inclined to get vaccinated and may have already been vaccinated. This is a group of individuals who have some reservations about the vaccine, specifically a sense that the mRNA vaccines were rushed to market. And secondly, they're not certain about the long-term side effects. And so really for this group, sort of two key messages are critical. The first is conveying the amount of research and development that went into the vaccines. In some instances, the scientific advancement goes back almost a decade, frankly. So no corners were cut to bring these vaccines to market. Only red tape was cut. That tends to be a good message. The second is to present data about those who were in clinical trials, who have been vaccinated now, in some cases for up to a year, to present evidence and data about any sort of side effects or long-term effect or not, as is the case with that particular group.
And finally, the last archetype that I'll just briefly cruise over, because these are our vaccine advocates. These are the folks that lined up to get that jab and are telling everybody about it and really promoting it. So when it comes to thinking how to leverage this group, it's all about using them as community motivators, giving them some tools to share stories and a platform, potentially volunteer opportunities, and to kind of spread the good word that everything is going well and it's a good thing to do for yourself and your community.
Okay, so with that, we've given you a high-level overview of the research and the research basis, as well as some concrete recommendations for how to address each of the behavioral-based archetypes. Certainly in the report itself, there are much more specific and concrete recommendations, and I would encourage you all to dig into that detail. We know that translating these ideas into practice, actually applying them, is trickier than it sounds. So I'm going to throw it back to Diane and to our panel to give you all some insight into how other leaders and organizations have done just that. Diane?
Thank you, David, and Caroline, for that overview. That was really a great backdrop for our panel discussion. So let me go ahead and welcome our panel. So starting again from Kaiser Permanente is Catherine Brown, who's the Senior Vice President of Enterprise Pharmacy Services. And from Christus Health, we have Marcus Pesquera. He's the System Vice President for Community Benefit, Equity, Diversity, and Inclusion. And from Salinas Valley Memorial Healthcare System, we have Alan Schubert, the Director of Marketing and Communication. Thank you all for joining us and helping us here today. So to get started, why don't each of you briefly introduce yourself, your organization, and the community you serve, as well as your role. So let's start with Alan.
Yeah, thanks for having me. I'm Alan Schubert, Director of Marketing and Communications at Salinas Valley Memorial Healthcare System. We're located in Salinas, California, which is on the Central Coast near Monterey, which some people might know. And Diane, I just checked our numbers this morning. We're at 67% of eligible people in the county being vaccinated. We have 14 cases of the Delta variant that we've seen in our county, but we know that might increase because the numbers in California as a whole are going up. So that's where we are, and that's what we're dealing with locally.
All right, terrific. Thank you. Marcus?
Hi, good afternoon and good morning, depending where you're at. First of all, great presentation, and I have to say, coming from the community health perspective, it's particularly looking at everything through the health equity lens, is so refreshing and different to see these archetypes, because no matter what your background is, all these archetypes are represented in those communities. I'm Marcos, and I'm the Vice President for Community Health at Christus Health, and Christus is a faith-based Catholic healthcare system headquartered in Dallas. We have facilities in Texas, all over Texas, as well as Louisiana, New Mexico, and then in South America, in Chile, Colombia, and Mexico as well. And frankly, our communities are rural, are urban, as well as suburban. So we got the whole bit.
Okay, thank you. And Kathy?
Hi, I'm Kathy Brown. I'm the Senior Vice President for Pharmacy for Kaiser Permanente, and I'm one of the leads in the Kaiser Permanente vaccine effort. We're located in 8 markets, 12 states. So California, Oregon, Washington, Colorado, Georgia, Virginia, Maryland, and Washington, D.C. And we have folks from our members are in very diverse lines of business. We have a very diverse membership base as well as an employee base. So when we look at vaccine hesitancy, we're looking at our members and how well they're vaccinated. We're about 70% across, but it varies by market, with the South being a little less, California and the West Coast being a little bit higher. But we also have variance amongst our employees. So looking at our employee vaccination rate, we're about 80% of our employees are vaccinated, but it may surprise you, some of our employees that aren't. So we have intensive care nurses, for example, that aren't vaccinated. So thinking about how do we reach employees is another thing that we're doing work on.
Yeah, great point. Well, let's dive into some of the report archetypes now. So what elements of those particularly resonated with what you're seeing in your communities and patient population, or your employees as well? Do you have any stories to bring some of these situations to life? So let's start with Marcos.
Sure. Well, I have to say first, I start personally. I identify with the reluctant Vaxxer for sure. I remember the first week that it was available in December, and I of course, I believe in all this, but I was a little bit hesitant. That point that David made about how quick the vaccine was developed, and then later on realizing that wasn't the case. I waited the first week and saw that all my colleagues were doing just fine, and there was no issues there. And sure enough, I put my arm out there, and by the mid January, I had the second shot as well. So it's you see yourself in these archetypes. Now, in our community, we've seen the spectrum of personas and archetypes. I saw a colleague that had heart failure, and he was right there first, and just to see tears coming out of his face about the relief of how nervous he was about contracting COVID, because it definitely would have been a pretty bad outcome for him. So I think that we can conclude, frankly, when I hear this, that many archetypes are compelled by understanding the impact of the shot in their families, in their friends, in themselves, and their neighbors, versus trying to interpret, some abstract statistical data, if you will. I do have an example of a steadfast opponent in our community. I was talking to one of our community health leaders where somebody came and said, listen, my Bible tells me that your body is a temple of the Holy Spirit, and I am not going to put anything that is not good in my body. And the person, of course, didn't, they did the right thing. They did not agree. They did not disagree, but basically refer them to their their faith leader to have a conversation. This person did have a good relationship with them. So they talked about smoking, they talk about alcohol and all these things and other behaviors that are bad for your body, but actually something to help protect your body from the virus was you got to look at it a little bit different. And actually that did change the mind of the person. But you're right, it takes time, and it's really a relationship building ahead of time.
Mm-hmm. Yes, great example. Those trusted messengers are so important. Kathy, how about you?
Well, I have a couple. I'll start with my daughters. My daughters are in their 20s, but they have a mom that's heading up a vaccine campaign, so they're vaccinated right away. But their friends, I talked to all their friends, and they're indifferent. I'm not at high risk. I'm in college, and frankly, that's the age group that's the spreaders. They're the ones out at stuff, and just they have to trip over it. It's not that they don't want it. It's just I can't be bothered. And so I totally identify that you have to trip over that vaccine for that indifferent group. So, a lot of their friends are now vaccinated because it was offered at their college or it was offered at a pharmacy. Bringing it to pharmacies really helped them. Like I walk past a CVS every day, right? So and big signs and totally social media messaging, really gets that group. And then not being able to go to things. So a wedding, a community wedding, and you can only go if you're vaccinated, or you have to wear a mask unless you're vaccinated. Those things really play well in that 20s and different age group. Mm-hmm. The other quick example, kind of on a different end of the spectrum, is a physician friend of mine. Now she got the vaccine really quickly as well, but when it came time for her 13-year-old daughter, she hesitated. And she said, kind of in the cautious supporter range, like, well, I was quick to get a vaccine, but this is an adolescent and isn't really tested enough. And this is a physician. And she did a lot of research. So she needed that trusted messenger. She needed to read the research herself. She needed to speak with folks that were in the infectious disease community. And so she needed that. So I thought a cautious supporter and that trusted messenger and doing that research worked for her. And then finally, the third one I would give really quickly is one of my ex-home health patients, an 85-year-old. I did home health up in Seattle, not a Kaiser member, but she wanted the vaccine, but she didn't want to go to the mass vaccination site to get it. She's 85, and she said, I'll do it when it's at my doctor's office or when it's at my pharmacy. So for her, she was a vaccine advocate, but she wanted it at a place she trusted, which is interesting, I thought. So when it was available within the physician office, that was something that helped her versus taking a free bus to a big mass vaccination site in the middle of the city. So I don't know, those are just three examples.
Great examples. Yeah, very unique approaches that we need to be thinking about.
Yeah, exactly. Thanks, Diane.
All right. Well, Alan, how about you? What kind of stories might you be able to share?
Well, since we all had a little bit of personal anecdotes, I would say I was a vaccine advocate, not only for the health reasons but I just thought, as much as I hate getting a shot, getting a COVID nose swab sounded a million times worse. So I was like, I'll take the shot over that. But seriously, I think, what resonates to me about this discussion is how long this might take. And I know in the report, there's kind of this timeline. And, I mentioned where we were at locally, 67%. Well, 3 weeks ago, we were at 66%. So we've moved a number 1% in 3 weeks. So that just shows me that the journey is going to be kind of long. And I think where we're going to get value of focusing is on that movable middle. And that's sort of what we've been doing here. So operationally, one thing that we've done as an organization is take our mobile clinic out. So we have people, I think, that fit into that indifferent, reluctant group that if you can give them an opportunity, and we've taken it to retail locations and everything, where it's just sitting there and we're making it available easily for them. And that's been something that has worked for us a lot. We've also done a number of live events. So we started getting really heavy into things like Facebook Live, where we could have a doctor answer questions and take live questions about the vaccine. And in our area too, especially around our immediate area, around our hospital, we're about 70% Hispanic population. So we really need to make sure that we're taking some of these archetypes and actually drilling down a little bit too into what matters to that group culturally. And one thing that does matter a lot is family. So some of our messaging has struck the chord of like, do this because it'll give you more time with your family. It'll allow you to do the things you want to do. So we've experimented with that a little bit. But again, I'd say we've had a really nice response to some of these live events, especially some of the ones where we've done in Spanish, where there might not be a lot of other outlets for that group to have their questions answered or easily find information online. And again, I think that's really targeting that sort of indifferent, reluctant, and cautious group that if we give them the right information at the right time or the right opportunity operationally to get the shot, they will do it.
Yeah, I think you're doing a great job too of just listening and really truly understanding your community and the different perspectives that come to bear. Very good. Well, let's just shift a little bit and think about how to apply some of these archetypes in the strategies in your role. So, Kathy, how are you using this information to guide the strategy at KP?
Well, it's interesting. I just was resonating with what Alan and Marcus said too. We've really moved from zone to man to use a sports, or person to person to use a sports analogy. We had these big mass vaccination sites. We were doing thousands and thousands of vaccines per day. It was super great. And then, now we're at this sort of point where the numbers aren't moving quite as, the numbers aren't going to move as fast. They're just moving slower. What we did at Kaiser Permanente is we took the archetypes, and it's just sort of a knowledge that everyone is different. And we built a toolkit. So we built a vaccine confidence toolkit, and it's a toolkit, not a recipe book. So that's important because this really has to be customized to each market. So we sent the toolkit, and what it did is we did education about the archetypes, so the archetypes that were presented. So we did education about the archetypes and what might work. And then we asked each market to really understand. We did a lot of analytics, and I heard Alan and Marcus talk about analytics in their market or what they're doing. So we did a lot of analytics with how are you doing in your market around with your 8 different age groups, your different populations, whether that be gender, race or ethnicity, social vulnerability index, your line of business. What are you, Medicare, are you commercial, you're employer based. We'd also did it by language, by income, by education. So we asked each market. So we did a vaccine toolkit. We asked each market then to look at their data and to really assess with where they needed to put their effort. And then we had a number of tactics. So again, this is sort of about taking this archetype and then putting it into specific tactics. And I can go into them, but I won't here unless there are questions. But the big one was, engagement. So how do we tailor information and engagement? Each archetype responds to different motivating factors. Information, convenience, community support. So how do you think about our engagement strategy? And there's a number of tactics you can think about underneath that, from social media to employer campaigns to just tailoring your information at the pharmacy counter, for example. So that's the first thing, was engagement. Second set of tactics was around trust. So community benefit or community-based organizations, how are we partnering with them? School, other school organizations, safety net organizations. And then the third thing around trust is that trusted messengers. So trusted messengers can be a healthcare provider, but they can also be community-based folks that are important to folks. So that would be the other second idea. And then the third idea would be, so you have information engagement, you have building trust, and then easy access. I mean, I'm thinking about our population management, expanding your clinic hours, making it easy. So my joke was anytime someone touched anything within Kaiser Permanente, and pharmacy alone, 250,000 times a day, someone's interacting with a pharmacy professional at Kaiser Permanente. It's a giant touch point. But you're also talking to advice lines, you're talking to your physicians. So really thinking about that access with making sure that we're touching our members and making that easy. And then finally, supporting the most vulnerable. So thinking about, can we go to patients' homes? How do we really support folks that are at the most vulnerable points in their care? So those are kind of some of the ideas, but it really goes with understanding that everyone's different, the archetypes, building a toolkit with various tactics, but you have to take those tactics and apply them to where you most need it. So that's kind of the strategy behind it.
Right. That's fantastic that you were able to thoroughly and in a comprehensive way have this cascade throughout your organization. So everybody's familiar with it and is aware of the tools that can be used depending on their situation. So well done. Thanks for sharing that. Alan, based on the archetypes, how can you tailor some of the communications to build confidence in the vaccine, do you think?
Yeah. And, I think since we probably do have a fair amount of marketing and communications people on here, it's also just acknowledging the situation we're in first. This is probably the first webinar I've ever done where I wish we weren't doing it. Like, I wish we weren't having this conversation. I wish we had to hit 85%, 90% without doing a lot of heavy lifting, but that's not the reality. So, as marketers, I think, we've started to open up our communities. So we thought about really going back to some of our traditional marketing, right? And that makes sense. It's appropriate, but we've got to keep focused on the vaccine issue as well. So I think we can do both of those things at the same time. A lot of us too have stood up a lot of many new communications channels. We've got new things we're doing. I mentioned the events we're doing. So we're not going to stop any of that. And I think what we need to do is take some of this information and figure out, of the tactics we're doing today, can we drill down more? Can we do something different? Can we leverage it to hit these audiences? So part of it, I think, and it's always an ongoing challenge, is again making sure this stays above the line, and as we're moving into new areas of work, that we keep focused on it. So, for me, the archetypes I've really learned about probably just in the last couple of weeks. So, I kind of foresee going forward again, looking at some of our work through this lens and figuring out again, some of these I think we're already hitting. We're already using some of the same messages, but again, it's taking this and doing an overlay and figuring out again, are there some opportunities here? But I really think, and David mentioned it, social media and things like that, that's where you're already messaging. I mean, most of us are getting social media messages out maybe every day, maybe multiple times a day. So are we making sure that we're working this in? Are we hitting some of the right audiences? And I think that's going to be key. So first and foremost, it's focus, it's doing this. And then again, it's looking at what you're already doing and figuring out how you can layer this in.
Great. Thank you so much. All right. A question for you on this, Marco. So what archetypes are most familiar to your community? And how do you think you could tailor a community health strategy to address those specific concerns?
Sure. I think the realization, like Kathy and Alan both mentioned, is that this is not going to be a fast thing. I mean, at the beginning, it was quick, it was great, we're so excited, and then zoom, everything dwindled. So it's going to require a relationship, and I think that's what I'm hearing throughout. So I think for us, Steadfast Opponent, particularly in rural areas, was an archetype that was we were a little concerned, and we are obviously. But partnering back with faith-based leaders, we went ahead and utilize our directors of spiritual care that are in our hospitals. They have relationships already with all these leaders, and we equip all these church leaders with all kinds of information and links and Q&A. We got them ready so they could, from the pulpit, basically advocate for us, and that has been very helpful. I think. Now, granted, this report and the way of looking at this is a little new, so we need to digest all this. But couching the vaccine as a way of taking care of your temple, the body, is really important for some of our communities. Testimonials, I was thinking about, from local individuals that suffered greatly from COVID or that transferred it to a loved one that suffered greatly because of it. Those are things that really pull at you when you see it's not just about me, but it's about a cause bigger than myself. Painting a picture in people's minds about, hey, let's get back to normal, to a sense of normal, how we used to be, kind of a thing. Q&A sessions with trusted local clinicians. I saw that in the report loud and clear. Benefits of herd immunity for some, but not for others. And I like the point that was made also about finding individuals that were part of the vaccine trials and taking advantage of that, because their experience needs to be heard, and they've been around for over, I'm going to say, 1.5 years now. So there's some people that are very reluctant because of this, the short, and they don't know what's going to happen, but they've been around for a while now. So I think that will be beneficial to bring these folks back, and we need help in identifying them.
That's a great point. Well, thank you for all of that. And I can hear how you're working with other organizations. You gave a good example of partnerships with faith-based organizations. But taking it maybe internal for a moment, based on all of your experiences, how can various professions, such as the ones represented in a little square here today, a strategist, a communicator, clinicians, people in the community, how can we work together more to accelerate some of this vaccine uptake? Any other ideas that come to mind? And Alan, I'll choose you to speak first.
Yeah, well, I guess I would go back to what I said a second ago. It's making sure that we're keeping it top of mind, that we're working. So on the marketing and communicator side, I think making sure that we're keeping it top of mind. We're putting messages out all the time. Are we getting enough, air cover on this one specifically? Because I do think there's a risk of, for largely, we're going to go back to thinking about promoting the things we've done in the past. Communities opened up, but we can't lose focus on that. So I think that's key. I also feel like, and there was a question I think may have come through in the chat or something, but about who's respected, who kind of has some authority. And I do think we're still riding a really good wave of people feeling good about their healthcare professionals, right? They trust their doctors, their nurses. There's a lot of good feelings toward how people responded to COVID-19. So I think we can still leverage that. I think having healthcare providers who can talk about their personal experience of getting the vaccine, if there's skeptical employees, I think that's great. So I feel like that's a real area that we could continue working on.
Great, thank you, Marcus.
We one of the bright lights about COVID, if there's one, is that we have come together to work on this like never before. And the way that we have worked with our clinicians and our communications and marketing folks, we developed an amazing tool. What I thought, it was a video of very diverse physicians from different countries and races and accents and everything, reading a letter to our communities about how to trust, to make sure that they, promote trust and promote them getting the shot. But also it's about acceptance and acknowledging the errors of the medical establishment in the past, the abuses in the past, and acknowledging that head on, but understanding that this is new and this is different. And I think that was effective. It was all over social media, which I think it helped. We also collaborated with physicians, particularly those that spoke Spanish, and with Univision and Telemundo, and get in front of them in the language of our communities. Because obviously I'm here in Texas. It's one of our states, so there's many limited English proficient populations there. So, and also, when you look at strategy, and they bring in all the zip code data, the gender, the race, and a way, frankly, of crafting this, it's refreshing. And to me, this report comes at a time where the Biden administration is really pushing, and like you said, Kathy, pharmacies and sporting events and summer festivals and places of worship is going to be super available. So it could not come at a better time.
That's great. That's right. And Kathy, any other thoughts on how we work together better on this, or any other community influencers that you see that you can tie in that have been useful?
I guess I would just say, I don't know, a couple things. One is that, the other thing is we're presenting these archetypes like they're static. And I think that we're all people. And I think the whole COVID pandemic has laid bare a lot of things societally. And it's all kind of plays into this vaccination campaign. And I think it'll move us forward as a society. So I share Marcus' optimism there. But I think people move between stages as they weigh the risks, the benefits, convenience of vaccination. So I think that's a sort of another thing to keep in mind, like the physician that, was first in line to get vaccinated for herself, but hesitated with her daughter. So I think that there is sort of the moving back and forth. And so I think that our strategies need to be agile as well. And it all comes down to, information and what are the channels. I heard Alan talk about a lot of channels. We're putting out information, trust, and who do you trust? Who do the different archetypes trust at what times of their journey? And how are we arming them? And then finally, access. How are we providing access at the time when they are ready to get the shot? So I think there's sort of those are, if I had to sort of summarize it, and then as a health system that we all represent, it's also knowing that it's a longer journey, it's a journey. And I think it's thinking that it isn't over yet. I do think there is in my organization, there's this giant push now to let's check this off and we're moving on to budget for next year or whatever we're moving on to. So I do think is keeping it in mind and keeping it in front of us as an organization, and keeping it in front of ourselves to continue. What are we doing about information? What are we doing on the trust factor? And what are we doing on access? And keeping that in front of us, even as so much pressure to move on.
Uh-huh. It's great counsel for all of us. I'm going to take a few of our questions from our attendees right now. We're running a little low on time, so let's jump into some thoughts from them. So we have an example of someone who's in a rural area where some medical professionals are not getting vaccinated, and their community knows it. So are there any recommendations for this kind of concerned skeptic when it's the medical professionals involved? And anybody want to jump in on that one?
I feel like I said that we're in rural places, so I'm going to have to say something. That's a difficult one, to say the least. Mm-hmm. One rural ministry that comes to mind, we have an amazing vice president for medical affairs, and she's a physician herself. That would be something that I would direct, frankly, that physician to talk to this person and kind of be able to express or have that physician actually go and address that individual. Now, granted, it is a journey, and it's like we said, we have to be so careful in how we deliver this conversations to move the needle. But that's where I would go. I would go and speak to an expert, and in addition to that you see as a manager or supervisor that you trust.
Yeah, very good. Oh, welcome back, David and Caroline. So I know there may have been some earlier questions that came regarding to the report. Let me jump in here and see. Looking through here. Let's see, do particular age groups gravitate more to particular archetypes? Have you seen that? I think you've mentioned some of that in your presentation. Is it consistent across the board for each archetype or just for some of them?
Yeah, I'll jump in on that one. And I think, as David mentioned at the onset, these archetypes kind of cut across many different demographics. And so I'd say for many, we saw different ages falling into different archetypes, but there were probably two that had more concentration of a particular age group or generation in them. And specifically the indifferent individuals, those tended to be more of the Gen Z or the youngest Gen Y population. And just kind of their mindset was, I'm healthy, it's not impacting me if I get COVID, you know, I'm sick for a little bit, everything's okay. So that particular archetype and age group paired well. And then also when looking at the healthy independence and some of the cautious supporters, some of the parents of kids that were at the age that could vaccinate, that tended to be some of the Gen X population, you know, in their 40s and 50s, have good health, or those concerns of, well, I'll get the shot, but I don't think I want my 16, 17-year-old to get it just yet. So those were the three archetypes, I guess, that had more concentration of particular ages.
Great. Thank you. There's a good wrap-up question that came up from somebody who submitted a question when they were registering. And if you could just think of one example, if you were to pick the one specific thing that you did that you believe led to the largest increase in vaccinations, what would that be? What was your favorite tactic of all? Let's see, I'll start with Alan.
Yeah, I think we got a lot of value out of the live events where we had physicians out answering questions, especially, as I mentioned, the Spanish events we did, just because there wasn't another avenue for that group to get the information locally. So I'd pick that one.
Great. And Marcos?
I will pick mobile vans and taking them to very places where you know, they're difficult to reach. So that to me was a great tactic.
Okay, terrific. And Kathy, do you have your favorite?
Oh, wow. Well, since I was in charge of access, I have to say I spent a lot of time thinking about where we would have that when somebody was ready and the trusted messenger and all of the marketing and everybody did their job and that person's now ready, the vaccine was right there, right where they're ready. So really did a lot of tactics around making sure vaccines were available when they were ready, whether that was a pop-up clinic, whether that was home health nurses, whether that was in pharmacies, whether that was in doctors' offices, and whether that was in other types of vaccination sites. So I'd say just really thinking about the access probably was my favorite.
Great. Caroline, I'll jump to you as well.
Yeah, I think one thing that we saw was how we were speaking to our member base. We went from communication that was like, sign up for the vaccine here, to if you have questions about the vaccine, here's how you can answer them, here's how you sign up, etc. So we opened that conversation moment a little bit early instead of just pushing out on people.
Can I add to that just really quick on the pharmacy side or on the peace side? So oftentimes as healthcare professionals, so I love the work that was shown here about archetypes. As healthcare professionals, we're often in the tell position. Here's why you should do it. And the archetypes really taught us, and we did a lot of training with our folks around the listening and coming to where people were as healthcare professionals. So I think that's probably my other favorite, just based on Carolyn and David's work.
Great. And finally, David.
This is like picking your favorite child. I don't know if it's even possible. Maybe I'll just pick up on something that Kathy and Caroline have pointed to. One of the specific tactics we used at KP was in partnership with labor to identify vaccine ambassadors in each of our medical centers. We did a fair bit of training with them, both on the archetypes as well as those frameworks that we presented at the front end. Really showing up then in department meetings and engaging with their colleagues, first from a position of listening and understanding. And I think that's really critical. So Kathy made the point, I think, as part of the discussion, that our employees and our workforce are in this mix too, and we can't forget them.
Okay, well, thank you very much. And we are at time at this point. So let me thank you, all of our speakers here today, for sharing your expertise and insights. David and Alan have kindly agreed to come back to participate and facilitate an additional member dialogue in a SHSMD member meetup on August 2nd at 12 p.m. Central. We do have a link for registration, which we'll provide in the follow-up message to the attendees of this event, or you can visit shsmd.org, shsmd.org/education for more information on that event. A replay of today's event will be posted to the Joining Hands for Greater Impact page later this week. So please keep an eye on that space as we continue to add more resources on hospital community partnerships. Special thanks to Julia Resnick of the Value Initiative, who is keeping the field updated on these resources. In addition, AHA was awarded a CDC grant that furthers our work in helping hospitals and health systems build trust around the COVID-19 vaccine. You'll find an extensive array of vaccine resources at aha.org/vaccine confidence. Special thanks to our AHA Vaccine Workgroup and its organizer, Dina Lindenberg, who has also assisted with today's conference. And Dina always ends vaccine meetings on a positive note. So here's one for you that she shared with me. It's a recent Commonwealth Fund study that said without a vaccination program, by the end of June 2021, there would have been approximately 279,000 additional deaths and up to another 1.25 million additional hospitalizations in the United States. So lives have been saved, and we have you to thank for that. We hope to see you again soon. Thanks for participating and have a great day. Bye-bye.